Thank you very much. My colleagues here have introduced the psychosocial factors influencing back pain, and my talk is how to integrate psychosocial aspect into the management of back pain. So, from previous presentation, we can see that the old model does not work all the time, and back pain cases is more complex, associated with multidimensional factors, not only biomedical, but also psychosocial factors that could be modifiable or non-modifiable factors, and could relate not only to the patient, but also the therapist as well. So the multidisciplinary team is the way to go with many of these chronic cases. And this is the outline that I'm going to follow. So to address this problem, we need to not only look at part of the picture, we need to look at the whole picture. And also we need not to only work as a multidisciplinary team, but an interdisciplinary team where each part of the member or each member know what the other is doing and continue with this care. So the standard care or standard education and the practice and physical therapy concerned with biomedical model to address physical impairments and correct them. On the other hand, the mental health concerned more with psychological or psychosocial factors. So what we need to do to enhance our practice, it's suggested to include psychosocial factors in our intervention to enhance the outcomes. And the evidence is aggregating regarding this issue, including psychosocial factors in the rehabilitation of chronic back patients. However, still there's a number of challenges, like we still lack the best practice and models, and we also need to include psychologically informed practice in our curriculum. We need to have experienced faculty and mentor to supervise others in this area. And we need to develop a healthcare system that identify at-risk patients at early age, at early time, and align them with the right provider. We need also to create clinical guidelines that include psychologically informed practice. So identifying biopsychosocial, it's not that simple. It's not equal side circles. It comes in different ingredients and in different sizes for each patient. So when the chronic back patient reach us is already mixed with each other. So it's difficult and challenging to assess and manage them. Typically, when pain starts, it leads to cognitive factors related to attention, beliefs, attitude, past experience, and self-efficacy, and catastrophizing, which can lead to emotional factors related to anxiety, anger, fear, and guilt. That can lead to inappropriate coping skills like fear avoidance, which maintain the vicious cycle of pain and or pain persistence. And also social and cultural factors play an important role in this maintenance of pain chronicity. So psychosocial factors can be looked at as prognostic factors. So they can be used as a screening tools to predict whoever patient will have a poor outcome. They can be used as a treatment modifiers, so as a clinical aid to know what management or intervention work better for the patient. They also can be used as a treatment mediator to monitor treatment through them. So I will discuss some screening tools in this regard. So the cerebromusculoskeletal pain screening questionnaire, there's a shorter form with 10 items that covers psychological and social factors, also covers some items in pain levels and perception of work. Start back tool is a more common and shorter one, easy to use. It classifies patient into three levels of risk categories of developing a chronic disability into high, medium, or low risk. And there's some items that covers pain, some items covers disability, and there's some item also covers psychological factors like fear and anxiety, catastrophizing, and depression. Also, we need to assess cognitive factors, and this starts from the patient interview and reviewing some of the self-reported questionnaires. We need to assess the beliefs, the attitudes about back pain. We need to assess the patient's expectation, catastrophizing, and pain self-efficacy. I will review some of the most common measures. So on the left side, you can see the pain catastrophizing scale. It measures the negative thinking of the patient regarding their problems. So it measures the magnification, like when the patient say, I'm afraid that something serious might happen. And also measures the rumination, so keep thinking about their pain. And also measures the helplessness, so feeling helpless to control or do something about their pain. In the right side, you can see the pain self-efficacy questionnaire. It measures how the patient see pain as disabling them to do activities, or if they can do despite the presence of pain. We need also to measure emotional and coping factors, and I listed here a number of measures that you can use, and it's very common to use them with the chronic back pain patients. I will review in the left side, you can see the fear avoidance belief questionnaire. It measures the fear avoidance beliefs regarding physical activity or regarding work. In the right side, this patient health questionnaire, it measures the major 9 symptoms of depression. So if we suspecting depression with the patient or depression symptoms, we can start with only 2 questions. If the patient got equal of 3 or more, then we can go further with the 9 items. And as the pain have been defined, and we know that it's inappropriate to measure this complex feeling experience with only unidimensional measures like the numeric pain rating scale or visual analog scale. We need to use multidimensional measures like the McGill questionnaire that measures not only pain intensity but the quality of pain. And I will review some interventions that related to psychologically informed interventions. This is the outline that I'm going to follow, and we need to acknowledge that it's important to know the importance of physical therapist relationship. It's have been shown to be associated with treatment outcomes, not only with musculoskeletal cases, but in different physical rehabilitation settings. So the factors influencing this relationship relate to active listening to the patient, be empathetic with the patient, being a friend with the patient, and also taking the patient opinion and preference into consideration. When I'm going to talk about patient education in this regard, and I'm not meaning that to use the anatomical explanation to the patient, because this have been shown to be to increase the fear with those patients. We need to use pain science, pain neurophysiology, pain biology, to listen more than talking, to assure the patient that it's okay to keep moving, keep bending. Pain does not equal harm. Of course, after ruling out the serious pathologies. So we know that most of the patients coming to us classified as non-specific low back pain. So, and assure them that their back is strong, so it's okay to keep moving. Pain education is a big topic. It starts with a full history, ruling out serious pathology, and knowing what the patient think about their pain and correct the incorrect beliefs about that. And we can add exercise also to the patient education. Hopefully, with time, their function will increase and their pain will decrease. The cognitive behavioral therapy initially applied in the mental health, it's been adopted or used in pain clinic rehabilitation since the 1970s. It analyzes the interaction between patient thoughts, patient feeling, and patient behaviors. And the best example here is the fear avoidance belief or the fear avoidance model. It's used a lot with chronic back pain. And to help patient adopting new behaviors, we need to have some motivational interviewing skills. We need to identify some behaviors that we want the patient to achieve, break it down to smaller pieces, and encourage them through the way. Something closely related is the graded activity. So we want the patient to keep going, keep being active despite the presence of pain. And so we need to assess at the beginning the initial therapeutic quota, the higher level of activity that the patient can do, and then increase from that, encouraging the patient to keep going. And for patients with higher level of fears, we need to ask the patient at the beginning to identify the most fearful activities through some pictures, through self-report questionnaires. And then we increase the level of that, increasing the level of fear. And when the fear diminishes, we increase the activity again. Acceptance and commitment therapy emphasizes observing thoughts and feeling without trying to control them. So from this perspective, it's wrong to say to the patient, keep fighting the pain, keep fighting. This has been shown to correlate with worse outcome. So there's number of intervention that we can do, mindfulness. So observing the feeling, observing the thoughts without judgment, without controlling them, and acceptance, and also try not to get lost with the thoughts, and adopting or trying to do valued activities that bring joy and happiness to the life of patient. And I'm going mostly to finish, but it's important to address also lifestyle behaviors. We know there's a bidirectional association between lifestyle behaviors and psychosocial factors. So we need to, with motivation interviewing skills, to help the patient to stop smoking, to adopt healthy diet, and to watch weight, and to try to increase the physical activity, and also to focus on how to sleep well, have a routine and hygiene for sleep quality and quantity. So to be truly biopsychosocial practitioners, we need to have a shift from pathoanatomical to multidimensional, and from clinician-centered to patient-centered, and also from pain relief to pain management. And maybe also we need to change our names from physical therapists to a longer, some more reflective name. Thank you.